Good evening, friends. We begin with our next session on acute myocardial infarction. As you all know, that heart attack is the leading cause of death, and identifying a patient who's developing a heart attack and investigating and management of such a patient is of great importance in saving lives and as treatment should be initiated as quickly as possible. This will help us in not only saving lives, but also reducing the extent of myocardial infarction and improving the quality of life in such individuals. Now, let us start with what is acute myocardial infarction. The main cause of myocardial infarction is a sudden acute occlusion of the blood vessel, which results in disruption of blood supply to the heart muscle. If we can give a comparison to what is happening today in our day-to-day life, is the stoppage of the Indus River Treaty with Pakistan, where we have abruptly stopped the water supply to Pakistan. And the outcomes of stopping the water supply is for us to see in the near future. Similarly, when the blood supply to the heart gets suddenly obstructed, we have what is necrosis and damage to the heart muscle. And this damage, depending on how long it is there, would decide whether the damage is permanent or whether it is reversible. Now, what are the factors for a heart attack? We can divide them into non-modifiable factors and modifiable factors. The modifiable factors are age. I think one cannot reverse the process of aging. And just as we have graying of a hair, wrinkle of the skin, we also have a progressive deposition obstruction of the blood vessels to the heart. Sex, males are more prone to develop a heart attack than females. But once females cross, they get into their menopausal age, then the incidence of heart attack in females is the same as that of males. Family history plays a very important role. And if there is a family history of heart trouble in the family, then your probability of getting heart attack is much higher in the cards. And it increases your genetic risk factor of getting a heart problem. The modifiable factors are hypertension. Hypertension is known as a silent killer, and it can precipitate myocardial infarction. Smoking, very important. And I think even staying in the city itself, staying in Mumbai, is almost equivalent to smoking 10 cigarettes a day without actually smoking. Probably living in Delhi probably would be 30 cigarettes a day. So if we smoke in addition to the environmental factors, then it adds to the 10 or 30 cigarettes, which we are already smoking because of environmental pollution. Hyperlipidemia, again, high levels of cholesterol can result in atherosclerosis and blockage of the blood vessels. And diabetes, the very important factor, and it's important to control your diabetes and keep your HbA1c under control. Again, depending on the age, the level of HbA1c would vary. However, an optimal control would be between 6 to 7. Lifestyle modifications are very important factors, especially obesity and sedentary lifestyle contribute in a major way to, in fact, obesity is an independent risk factor for developing heart attack. What are the other etiologies of heart attack other than atherosclerosis? Sometimes a severe coronary artery spasm can occlude the lumen of the coronary arteries totally and can result in ischemia and myocardial infarction. There could be embolism, which could be because of left atrial thrombus, or it could be because of atrial fibrillation, which can throw off an embolism, which can cause a coronary artery or obstruction, and a diffuse vasculitis. Anything disease like aortoarteritis or SLE can cause obstruction of the blood vessel and can result in a myocardial infarction. What happens when there's a total obstruction? Early stages, necrosis begins within hours, and then you will have neutrophil infiltration, macrophage activities, which tries to clear up the debris in 3 to 7 days. What is the gross pathology of a patient who has developed an infarction? There will be initially that area will become pale. After that, as a response to the occlusion, there is recruitment of smaller blood vessels, and you can have hyperemia. And because of necrosis of the heart muscle, subsequently you can have thrombus formation or even the rupture of myocardium. What is the pathophysiology which leads to necrosis? Mismatch between oxygen supply and the demand of the myocardium. Anaerobic metabolism causing increase in the lactic acid buildup. And subsequent to this, there's a dysfunction where contractility drops and electrical instability arises. What is the clinical presentation? The classical symptoms of a patient presenting with myocardial infarction is left-sided retrosternal chest pain, severe excruciating pain, as if the patient would complain of as if a ton of some mattress kept in the chest, and there's a crushing effect on the chest wall. This is a very typical presentation, and patient will be sweating profusely. Patient will be very restless. However, there are other symptoms also which clinical presentation, wherein the patient could have radiation on the page to both the arms. It could be to the fingertips, especially the medial aspect of both the palms, or sometimes you can have pain in the interscapular region, in the back region. Very rarely you can also have pain in the epigastric region. So depending on the type of involvement of the infarct, the radiation of the pain would vary. So the typical pain would be on the left side, in the retrosternal region, but you could have transmission of pain to both the arms, the back, the jaw, and to the little fingers of the hand, and it can be to the epigastric region also. The second presentation could be that of dyspnea or breathlessness, where a patient goes into pulmonary edema, and this patient presents to you with acute severe breathlessness. Excessive sweating is undue sweating, which is not precipitated by any particular cause, can be one of the outcomes of the. What are the physical signs indicative of developing myocardial infarction? Severe anxiety. The patient may, because of severe vasoconstriction, the patient may look pale. Patient would have tachycardia depending on the extent of infarct, or whether the patient is failure. And on examination, you may find the patient's lung congested. There may be crackles, or clinically, if you try to auscultate, in some patients, they may have a third heart sound, which is called as a left ventricular gallop. What are the investigations which are performed in patients developing with a myocardial infarction? It depends on what type of it, whether it's a total occlusion or whether it's a partial occlusion. The ECG is plays a very important part in picking up early myocardial infarction. If there is a total occlusion, then you will have the typical hyperacute changes of ST elevation, If it is in the anterior lead, it will be, if it's an anterior myocardial infarction, it will be from V1 to V6. If it's in the inferior wall, you can have ST elevation in 2, 3, and AVF. If it is in the posterior wall, you probably would have tall R waves in V1, V2. And if it's a non-STEMI, where there's a partial occlusion, then you may have ischemic changes in terms of T-wave inversion, either in the anterior leads or the inferior leads or lateral leads. One very important fact is that development of a left bundle branch block could be the first indication of an MI in a patient, in an elderly patient. So a left bundle branch block should be taken very seriously in terms of if the patient has developed acute coronary syndrome or not. What are the investigations which are very important? I think today, HS trop I or troponin, high sensitive troponin is one of the very important and very sensitive markers of developing ischemia, and it gets elevated within 3 to 12 hours of developing an infarct. CP can be less specific for reinfarction, but I think today a high sensitive troponin is a very important marker for ischemic heart disease. Additional diagnostic investigations other than blood investigations would be an X-ray test, which would be useful in assessing whether the patient has got pulmonary edema or not. An echocardiogram is a bedside test, I think, which should be done in all patients who present to the ICU. And it's a very useful non-invasive test which immediately helps you in identifying whether the patient has developed infarction, he's got or whether the patient has any valvular problems or any leakage of the valve. So an echocardiogram, in fact, with the help of echo, we can also pick up whether the patient has developed any ventricular rupture or a cardiac rupture. This would help us in identifying a critical situation and making critical moves to salvage the myocardium and save lives. Today, angiography has become it has become a very important tool in diagnosing an acute coronary syndrome, and especially when a patient is developing an infarct. That is one of the most, it's a gold standard to identify an acute occlusion and very useful in picking up and treating patients early. Angiogram today is a very useful tool, and cath labs today are available, especially in an urban setting. Cath labs are available around the corner, and help should be taken to evaluate the extent of coronary disease. Management of myocardial infarction, emergency medical services would be, in fact, today if a patient comes, as soon as the patient comes to the ER, patient should be, if the patient desaturated, start oxygen. Patient should be loaded with antiplatelet drugs. In fact, if the patient is going to take to the cath lab, load him with dual antiplatelet drugs, start upon oxygen if oxygen is low, and the patient should be given an option. If he has come within 90 minutes of developing chest pain to the hospital, he should be given an option of being taken straight to the cath lab, and if there's a clot thrombus, to open up the clot thrombus and restore the blood supply as early as possible. Or if the patient has come beyond 90 minutes, or patient got admitted in a setting where cath lab facilities are not there, then patient should be thrombolized. The other important things is to obtain an IV access as soon as possible. ECG is very important. Biomarkers should be immediately sent as soon as the patient gets admitted, and especially if the patient has to be taken up for a coronary angiogram, then we need to get the hemoglobin of the patient, the renal status of the patient, and the routine antiviral markers which should be performed before the patient is. As I mentioned, the option of treating a patient should be either primary angioplasty, which has become an established mode of treatment, and if reperfusion is achieved within 90 minutes of myocardial infarction, developing an infarct, then the damage to the necrosis to the heart muscle is as little as possible. But if it is not possible to restore blood supply in 90 minutes, then fibrinolytics should be offered. Either we can give retiplase or we can give streptokinase if retiplase is not available, and try to restore the perfusion of the heart muscle. Suppose if after giving thrombolytics, if the chest pain persists or if the ST elevation persists, which tells us that reperfusion has not been established, in this case, these patients need to be sent to the cath lab for urgent investigations and management. Assess the risk of the patient using the TIMI scale and the Grace scores. Give antiplatelets, dual antiplatelets, and if required, give the patient heparin, either low molecular weight heparin or the regular heparin. Beta blockers during an acute phase, if given, provided the patient not in failure, helps in reducing the oxygen demand, and statins can be given in acute phase because it is known to be anti-inflammatory, and it acts in multiple ways in reducing the ischemic burden on the myocardium. Once the patient has been admitted and he's been given antiplatelet drugs, he's been given statins, he's been given beta blockers, we can also give him ACE inhibitors, which helps in remodeling the myocardium. Or the patient, and subsequently the patient should be given the choice to be taken up for either a primary angioplasty or he should be taken up for thrombolysis. Once the patient is stabilized, then we should decide about the long-term management of this patient. I think long-term management would be, first is an advice in counseling on stopping smoking, a good advice on diet, and regarding the amount of exercises, I think it should be referred to a good cardiac rehab center where he's gradually mobilized and under supervision, he's given exercises to enable him to come back to normalcy as soon as possible. The potential complications which can take place in acute myocardial infarction, arrhythmias. In fact, ventricular fibrillation or ventricular tachycardia is one of the major causes of sudden cardiac death following acute infarction. And if the patient in the ICU, he can be cardioverted with a defibrillator. Either a 320 joules should be given, which can help in cardioversion and restoring the rhythm. If the patient is failure, where because of a large extended infarction, then all the measures to reduce the failure and minimize the myocardial damage should be initiated, which includes giving a combination of vasodilators, ACE inhibitors, diuretics, bronchodilators, and if required, subsequently once the patient is better, patient can be given beta blockers. If the patient presents to you for the first time with cardiogenic shock, where the blood pressure is less than 90, urine output is dropping down, then this patient may require vasopressors like Norad or dopamine or dopamine, and if need be, may require a aortic balloon pump to assist him as a bridge to reperfusion where he can be taken to the cath lab. So, enhancing outcomes in acute myocardial infarction is early recognition, prompt diagnosis, and early therapy will help you in a timely reperfusion, quick reperfusion, saving myocardium. It is correctly said that time is muscle, and timely intervention and timely prevention of damage to the heart muscle is extremely important in preventing next or resulting in good outcomes and faster recovery of the patient. I've given you a brief overview of how a patient can present with myocardial infarction, how we need to how we need to suspect the possibility of developing infarction, take an ECG as early as possible, do blood markers, which gives you a very high index of suspicion and gives you uh, an idea about whether the patient is likely to have ischemia or is developing infarction. And if the patient comes within 90 minutes, it should be offered either primary angioplasty or reperfusion therapy. After you reperfuse, the patient has STs have come down. Within the next 24 hours, the patient should still be taken up for an angiogram, reperfuse, and if there is an occlusion over there, either you do a thrombosuction, remove the clot, put in a stent over there, and re-establish perfusion in the heart muscle. So today, the mantra for managing acute myocardial infarction is establish reperfusion of the heart muscle as early as possible. That saves lives, that results in better outcomes to patients. Thank you so much. Until we meet next time. If there are any questions, we can, I'm willing to take the questions before we meet for the next time. Dr. Bhatt?
Yes.
Do you have any doubts about my management of acute myocardial infarction? Any questions you would like to ask?
No, sir.
Okay. Anyone else would like to ask any questions? I've kept it simple. I've kept a very simplified approach, investigation and management of myocardial infarction, so that you all can pick up a patient of myocardial infarction, have a good idea of suspicion of a patient developing infarction, and so that treatment can be initiated early and it can help you in saving lives. I think as there are no more questions, we will conclude this session until we meet next month, the last Saturday of next month. We will let you know what is the topic for our next meeting. Until then, namaskar, goodbye, and thank you so much for.
Sir.